Hi everybody, we're going to talk about liver and hepatitis in this lecture. We're going to talk about the liver and hepatitis in this lecture. If you look here at the picture, remember this is a mirror image, you have the liver with the gallbladder just beneath and the ducts just beneath that, cystic, common, and comic hepatic duct with other organs below. So here we have a 28-year-old man. He comes to the office and he complains of itchiness, mostly on his legs and feet, for the past few months. He's seen dermatology with little relief. The past weeks he's noted that his eyes and skin seem to be turning yellow. His stools are the color of clay and his urine looks like tea. Mild fatigue and weight loss in the review of systems, and he has no abdominal complaints. So if we look at painless jaundice, we'll see that generally previously physically healthy adults are more likely to have a viral hepatitis, whereas a 75-year-old older adult, we would more suspect a malignant process of the bile ducts or pancreas or something like that. So when we talk about jaundice, what do we mean? Remember, jaundice is the yellow discoloration of the skin's scleromucous membranes, and it's caused by bile pigments of conjugated or unconjugated bilirubin. Presentation of jaundice may appear acutely or chronically. Oftentimes there's evidence of bile duct dilation. And when we use the terms conjugated and unconjugated, what do we mean? Okay, let's review. Bilirubin is a breakdown product of heme, which in turn is a part of the hemoglobin molecule that's in red blood cells. That yellow pigment is responsible for the yellow color of jaundice and bruises. When old red cells pass through the spleen, those macrophages eat and break down the heme into unconjugated bilirubin, which isn't water soluble. That unconjugated bilirubin is then sent to the liver, where it conjugates the bilirubin with a glucuronic acid, making it soluble in water. Most of this conjugated bilirubin goes into the bile and out into the small intestine. So, since an increase in serum bilirubin could be either because you're making too much bilirubin, usually due to an increase in red cell breakdown, or because you can't properly remove bilirubin from the system, either your bile ducts are blocked or there's a liver problem like cirrhosis, hepatitis, or even an inherited problem with the bilirubin processing. So, the labs will report total bilirubin levels and the percent that is conjugated versus unconjugated. If you have a lot of bilirubin around and it's mostly unconjugated, that means it hasn't made it to the liver yet. Too much heme being broke down, perhaps exceeding the pace of liver conjugation, or there's something wrong with the conjugating capacity of the liver, like a congenital condition like Gilbert's syndrome. However, if you've got a lot of bilirubin around and it's mostly conjugated, that means it's been through the conjugation process in the liver, so there's something preventing the secretion of bilirubin into the bile. In this case, like hepatitis or biliary obstruction, and the bilirubin is backing up into the blood. As far as jaundice, there are three types: hemolytic, hepatocellular, and obstructive. With hemolytic, there's excessive destruction of the red blood cells, and this results in elevations of indirect bilirubin that's bound to albumin. However, it doesn't spill over into or discolor the urine. With hepatocellular jaundice, we look at the viral hepatitis A, B, C, D, and E. Just an FYI, there is now a G hepatitis that's often associated with hepatitis Z, the clinical significance of which is unknown. Other things, drugs, alcohol, and cirrhosis cause this hepatocellular jaundice. And this results from the inability of the damaged hepatocyte to extract, conjugate, and excrete the bilirubin. With obstructive jaundice, it's caused by a stone, stricture, or cancer, or anything obstructing that common biliary duct. So hepatitis is inflammation of the liver, considered chronic if it continues for greater than 6 months. Viruses, alcohol, medications, it can be an autoimmune disease or metabolic defects. When you have a case of hepatitis, it's probably best to refer to a specialist for optimization of care. As far as pathophysiology, there's widespread inflammation of the liver, and degeneration and necrosis occurs of the cells, as well as enlargement of certain cells. This inflammation interrupts the bile flow, and sometimes hepatocytes do regain normal function, and this regeneration may take 3 to 4 months. The systematic effects are due to the antibody-antigen response, and we have this cell-mediated immune response occurring at the same time. There are 5 types of viruses: A, B, C, D, and E. B, C, and D can cause chronic infections, and they all present somewhat similarly with different levels of severity. So manifestations present in 3 separate phases: pre-icteric, icteric, and post-icteric. In the pre-icteric phase, we have the constitutional symptoms and perhaps some right upper quadrant pain. In that icteric symptom, this is where we have the jaundice that creates the clay-colored stools, the discolored urine, the itchiness, the anemia, and bleeding, clotting disorders. And post-icterically, we go back to the malaise, and that hepatomegaly slowly diminishes. When the patient presents acutely, it's very similar to other mild viral illnesses, with the fatigue, malaise, joint pain, nausea, headaches, some abdominal pain, may have some jaundice, and jaundice is rarely present in the hepatitis viruses other than hepatitis B initially. With chronic hepatitis, viral hepatitis, this is present more than 6 months from initial exposure. Mild disease, there's minimal inflammation. However, with severe disease, we worry about cirrhosis, liver failure, and hepatocellular carcinoma. Initial diagnostic testing should include a complete liver panel, CBC, differential and platelets, clotting, PT, INR, PTT, serologic tests, ANA, lipid panel, and TSH. The serologic test or the antigen antibody testing. Complications of these viral illnesses can be chronic persistent hepatitis. There is a long, prolonged convalescent period, fatigue, hepatomegaly. The LFTs just continue to remain elevated. Chronic carrier state is present when these folks are contagious long term. There are some blood disorders that can be a possibility: cirrhosis, liver failure, and cancer. So let's move forward. We have a 34-year-old man presents 2 weeks after returning from a month-long trip to India. He denies attending any pre-travel immunization clinics, and he did not take prophylaxis of any sort while in India. He reports a 6-day history of malaise, anorexia, abdominal pain, nausea, emesis, and dark urine. He admits to dietary indiscretion in that he consumed a salad at the roadside vendor 3 weeks before the onset of his symptoms. On examination, he's jaundiced. His ALT is 5,660. Remember, any elevation over 1,000, you think liver infection, hepatitis. The total Billy is 9. His serum IgM antibodies are detected. Because the IgM antibodies for hepatitis A are detected, this tells us that he is currently acutely infected. M, immediate or miserable, IgM. Okay, hepatitis A, the incidence, new cases, 1.5 million cases per year, small percentage of those in the U.S. Transmission, fecal-oral, infected water supply, and ingestion of uncooked shellfish. Rarely is the severity high. Usually it's self-limited and patients recover on their own. The incubation period, 2 to 6 weeks. And we have antibody detection for diagnosis. Listed here we have the geographical distribution worldwide. The prevalence is low in the United States. However, with increased travel, that puts more and more of us at risk. So with hepatitis A, patients are most infectious during the 2 weeks before they have any onset of symptoms and 1 to 2 weeks after symptoms start. Risk groups, high-risk groups include travelers, American Indian reservation occupants, Alaskan Native village people, and people around those outbreaks. So as far as signs and symptoms, that preicteric phase lasts about 5 to 7 days. In this stage, they would have their onset of nausea, vomiting, abdominal pain, and constitutional symptoms. That icteric phase, they would have the dark urine, clay-colored stools, jaundice, and pruritus. And on exam, they may have right upper quadrant pain, some organomegaly, some enlarged lymph nodes, even some bradycardia. Remember, when patients develop that icteric phase, their preicteric phase symptoms usually diminish. So as far as diagnostic testing, the presence of IgM antibody in the serum confirms diagnosis of recent acute hepatitis A infection. The IgM is positive immediately after infection. IgG, on the other hand, is positive lifelong after some time after acute infection. Once infected and recover, the antibodies to the virus then provide protection for future infections with any hepatitis A virus exposure. Oftentimes we'll monitor LFTs every 2 weeks until they are within normal limits. So prevention, immunization, good hygiene, sanitation are key factors in prevention. As far as treatment, the CDC recommends for people with no previous history of immunization that they undergo the hepatitis A vaccination or immune globulin as soon as possible after any suspected exposure. Fortunately, about 99% of those infected will recover without treatment, and severe illness is well less than 1% following hepatitis A infection. Let's move forward. We have a 40-year-old asymptomatic Chinese-American man who presents for routine visit with an elevated ALT, about 55. His mother died of hepatocellular carcinoma, and his middle-aged sister has hepatitis B infection. He has a normal physical exam and has no stigmata of liver disease. Let's look at another gentleman. 30-year-old African-American man presents with nausea, vomiting, mild right upper quadrant pain, and myalgia for 7 days. He's sexually active and has had multiple sex partners in the past 6 months. He has a history of gonorrhea and chlamydia. He has been tested for HIV and has been negative on several occasions. His exam reveals enlarged liver and jaundice. His CBC, WBC, coagulation profiles are all normal. However, his hepatitis B serologies are positive for hepatitis B surface antigen. His hepatitis B virus DNA level is high. So these two separate presentations have a common etiology as the cause of concern. If we look closer at hepatitis B, you'll see that there are 140,000 up to 320,000 cases per year in the U.S. The incubation period is rather interesting, 45 days up to 6 months. Transmission, bloodborne, sexual, perinatal. The course may be mild, however, it may be also severe and actually into fatal disease due to primary liver cancer, cirrhosis, etc. High-risk groups include IV drug use, multiple partners, infants born to infected moms, healthcare workers, and patients receiving dialysis. Remember, hepatitis B virus can be found in blood, tears, cerebrospinal fluid, breast milk, saliva, vaginal secretion, and seminal fluid. Here again, you have the geographical distribution. Again, United States has low prevalence. However, with increased travel, many of us are at risk. With acute hepatitis B, symptoms may include fever, chills, malaise, arthralgia, and a skin rash. Jaundice, nausea, vomiting, right upper quadrant pain occur in about 30% of patients presenting with acute hepatitis B. As far as chronic disease, most folks are asymptomatic until they develop carcinoma or cirrhosis or its complications, which include liver failure. So as far as physical exam findings, you may have organomegaly with some jaundice. With chronic hepatitis B, you may have palmar erythema and spider angiomata. You may have some signs, perhaps of portal hypertension, and this would include ascites, jaundice, and ectaresis. And this is that liver flap. It's a flap of the hand that is common with hepatic encephalopathy. There may, however, be a completely normal exam in patients with chronic hepatitis B if they do not have the complications. Okay, again, diagnostic testing. Hepatitis B surface antigen. This would be present initially and remains elevated in patients who are chronic carriers. The hepatitis B core antigen is present when somebody has the disease or has had the disease, and antibodies include IgM and IgG, and then that hepatitis B-E antigen is a indicator of infectivity. It is helpful in predicting which patients may move on to have chronic hepatitis B. Listed here are the hepatitis markers and what they stand for. This is the whole battery ranging from A all the way to E. This is a summary slide. Remember, anytime you see the anti phrase, that's looking at antibodies. But on the left, you'll see the hepatitis type. Second, you'll see the markers of acute disease. And as you see, for the most part, there's antibodies listed in each of the 5 categories. Markers of chronic disease, you'll remember that A and E have no markers, and hepatitis B, C, and D have their antibodies, and with hepatitis B, that antigen present as a chronic disease marker. And then naturally recovery, you would see antibodies present in A and B. For C, you would see no virus present, and D and E have no markers of recovery. So in review for acute hepatitis B infection, this is diagnosed by a simple blood test that detects the antigen, hepatitis B surface antigen, and the IgM antibody for hepatitis B core antigen. These antibodies develop in the blood in the early stages of infection at the time when symptoms appear. The antibody to the hepatitis B surface antigen, this develops after active infection and serves as an indicator for immunity long term. So here we have another summary of specific indicators. The antibody to hepatitis B surface indicates that the individual has received the vaccination or immunoglobulin or is immune, had the virus, and recover. The anti-hepatitis B core indicates present or past infection and lasts indefinitely. IgM antibody indicates recent infection within the last 4 to 6 months. Hepatitis B-E antigen indicates high infectivity and predictor of chronic hepatitis, and hepatitis B surface antigen indicates acute or chronic hepatitis B. Its persistence for 6 months after acute infection indicates progression to chronic hepatitis. If we look at treatment for hepatitis B, we see that there's no treatment for acute hepatitis B. For chronic hepatitis B, there are 2 approved treatments, interferon and the antiviral Epivir. Only patients with active hepatitis B virus are candidates. The drugs usually shouldn't be given together. Should be noted about 35% of patients treated with injections of interferon for 4 to 6 months will have long-term response. Remember, there's a lot of side effects. Many of them actually resemble hepatitis itself. And also, we have to address bone marrow issues by monitoring white blood cells and platelets. And naturally, any patients with chronic hepatitis B should be immunized against hepatitis A. Treatment usually continues for about 12 months after the seroconversion of the hepatitis B surface antigen. The WHO guidelines were just put out this month, and you see that the 2 antivirals are listed as preferred drugs for chronic hepatitis B because of their limited side effects, convenience, and availability. Sicker patients naturally should be given higher priority for treatment. And the blood test, the LFT to platelet ratio index, is recommended as a resource when there's limited areas of access. However, if financial issues aren't a barrier, then we use the FibroScan. FibroScan is available everywhere except the U.S. It stages fibrosis. It's an ultrasound that looks at liver stiffness. Its limitations is that it is not accurate with ascites or obesity. And naturally, we always monitor patients for liver cancer and determine whether treatment should be stopped at what point in time, as far as if they have recovered. There are 2 types of immunization: hepatitis B vaccine and the passive immunity with hepatitis B immune globulin. The immunization schedule is typically given at 0, 1, and 6 month intervals. However, there is loss of immunity with immunosuppression in those with diabetes and on renal dialysis. And the hepatitis B vaccine can be combined with hepatitis A vaccine. I think it's called Twinrix. And it should be noted that not everybody responds serologically to immunization. Many think it's 100%, but it's somewhere around 85%. So we need to re-immunize with negative titers. Listed here are settings in which hepatitis B vaccine should be given. And most of us know all these, but just take a look to make sure in review. So moving on, we have a 50-year-old man that presents with 5 to 6 months of gradually worsening abdominal swelling, intermittent hematemesis, and dark stool. He denies chest pain, shortness of breath, family and medical history non-contributory, past surgical history positive for back surgery with transfusion 1980. He uses occasional alcohol. He's 6 foot, weighs 100 kilograms. Blood pressure is good. Exam is significant for spider, angiomata, upper chest gynecomastia, and a fluid wave is present of the abdomen, otherwise negative. The incidence of hepatitis C is about 36,000 cases per year in the United States, and this accounts for about 43% of new hepatitis cases. Transmission is usually blood-borne, however sexual and perinatal also. Risk groups are the same as with hepatitis B. The incubation period is interesting, anywhere from 14 days up to 6 months. And diagnostic testing includes the antibodies to hepatitis C and D. Interestingly, about 10% of people with hepatitis C infection have no recognized risk factors at all. Patients are contagious for the virus 1 to 2 weeks before they develop symptoms, and this continues through the clinical course and for carriers can last indefinitely. Prevention occurs through screening of donors, and hepatitis C can lead to chronic disease and liver disease frequently, and is the leading indication for liver transplant. Okay, so with diagnosing hepatitis C virus, we do a blood test that detects hepatitis C antibodies in the blood. If this test is positive, we then move on to a second test to confirm the diagnosis, and then we move along with liver enzymes. The antibody to hepatitis C may not be present the first 4 weeks in about 30% of patients, and in other patients it might not be detected for 5 to 12 months. This antibody in approximately 60% of people may show as early as 5 to 8 weeks after exposure. So you see the variability in all these percentages. Over 80% of hepatitis C infections become chronic, which means that liver enzymes remain elevated for at least 6 months after that acute infection. A liver biopsy can identify both the type and degree of the damage, thus the severity of the disease. Interferon and antivirals are given to boost the immune system and decrease viral count. And adverse effects can be similar to those of the virus themselves, mainly constitutional symptoms, and we look at blood cell counts, monitoring them after the medications are given. So there are 3 types of interferon used, and a combination of one with the ribavirin is used to treat the hepatitis C. The combination therapy has been shown to eliminate the virus almost 50% of the time after 6 months of treatment. Patients with cirrhosis often don't respond well. We try to have these patients maintain a normal life as possible, eating a well-balanced diet and exercising. Again, side effects can include anemia, blood disorders, neutropenia, thrombocytopenia, depression, and fatigue. We watch these patients closely for those. And we continue treatment for 6 to 12 months depending on the response and the genotype. So in review, alpha interferon, again commonly used with ribavirin, injections 3 times a week for 6 to 12 months. Almost 50% show complete response rate where no antigen is present with a blood test following treatment. However, retreatment may be necessary should this not occur, and it's most effective with hepatitis C if there are low RNA levels and absence of cirrhosis. Side effects: headache, fever, fatigue, arthralgia, myalgia are common, especially with the initial injections. There also may be medication-induced thyroid disorder and pulmonary fibrosis. So let's say a few words about hepatitis D. This virus can't survive on its own. Hepatitis B virus must precede hepatitis D virus. It transforms a mild hepatitis B infection into a severe, progressive, chronic, and active hepatitis, sometimes cirrhosis. It contributes to a fulminant hepatitis B. It's transmitted percutaneously. Otherwise, same information as with hepatitis B. It's just an adjunct. And here you see the geographical distribution of the hepatitis D that would, you'd think, follow the distribution of hepatitis B. Again, the distribution low in the United States. Briefly, a positive test for the antibody for hepatitis D in a patient with acute hepatitis B indicates co-infection. Patients with chronic hepatitis B have a positive hepatitis D test and are then super-infected. Treating the hepatitis D, again, interferon treatments are beneficial in a small percentage of patients. Immunization against hepatitis B would naturally prevent the hepatitis D virus. Hepatitis E transmission is fecal-oral, poor sanitation. The incidence is more likely Asia, Africa, and Mexico. The incubation period 15 to 2 months. There is no test for immunity. Similar to hepatitis A, not as easily transmitted, and there is no carrier states. Again, we're learning more and more about hepatitis E as we move forward. Testing for the antibody for hepatitis E is usually reserved for returning travelers from the developing world in whom hepatitis is present, but other hepatitis viruses cannot be detected. There is no current treatment for hepatitis E. Supportive measures. Hepatitis G, briefly mentioned earlier, clinical significance not known. Co-infection with hepatitis C is common. It's transmitted percutaneously. And interestingly, in patients with HIV, co-infection with hepatitis G improves survival. Chronic hepatitis, hepatitis B and C, characterized by elevated ALT and AST for more than 6 months. Cirrhosis would occur in about 40% of these, and unfortunately hepatocellular carcinoma in 20%. Management. How do we manage patients with viral hepatitis other than pharmacological methods? Well, we need to keep an eye on the labs, continuous observation of PT, PTT, albumin, electrolytes, glucose, and CBC. Educating the patient regarding illness and transmission, treatment side effects, and the importance of avoiding alcohol and other harmful medications. Maintain a good fluid balance, adequate hydration, adequate nutrition, blood precautions with hepatitis B and C, and naturally avoiding the medications metabolized by the liver, acetaminophen, iron, etc. And our final slide for this lecture includes follow-up measures. Follow-up should be 6 to 12 months after acute illness, where we're measuring the liver panel, measuring antigens, and also monitoring for chronic infection. Surveillance continually for hepatocellular carcinoma, and also consultation referral, keeping each other posted. Liver biopsy may be necessary, continuous monitoring of symptoms. And that is all for this lecture. We'll move on to cirrhosis.